Yeah, you can see the link below, and you can be able to join this Twitter audio interactive session with Dr. Murli Bharadwaj. So we welcome Sankit. Hi, Sankit. Yeah. So we are online on the YouTube also parallelly now. Okay. So generally, when we prepare, we all feel that somebody asks questions, we answer. That is the whole spirit behind starting this audio interactive session. So yeah. So Sankit, are you ready for taking a small fight with me?
Yes.
Good, good. So my first question to you is, have you heard of VOGT triad, walked triad of tuberous sclerosis?
Yes.
So now tell me, what are the three features of the walked triad of tuberous sclerosis?
It's epiloria, epilepsy, low IQ, and autonomic sedation.
Right. Low IQ is mental retardation, seizures, and angiofibroma. Actually, these three are considered to be the walk triad of the tuberous sclerosis, is what we need to remember. Now, tell me, what is that neurocutaneous syndrome where you find a track calcification on the skull X-ray?
Sturge-Weber syndrome.
Very good. That is in the Sturge-Weber syndrome. Yes. Now, in the neurofibromatosis, you have type 1 and type 2, right?
Yes, sir.
So, do you remember any chromosome number of type 1 and type 2, commonly forgotten?
Chromosome 17 and 22.
Very good. So, chromosome number 17 is the 1, and 22q is a 2. Very good, very good. Now, neuropathies are divided into demyelinating neuropathies, right? And axonal neuropathies. What is the most common hereditary cause for a demyelinating neuropathy? Any guess?
Multiple sclerosis.
Multiple sclerosis is not necessarily hereditary, right?
Yes, sir.
So, have you heard of a condition called Charcot-Marie-Tooth syndrome?
Yes, sir.
So, that is considered to be the most common hereditary cause of the demyelinating type of neuropathy, right? Now, basically, whenever there is a neuropathy, you can get paralysis. A paralysis can be an ascending paralysis or a descending paralysis. Can you tell me two conditions where you find descending paralysis? Descending paralysis. Okay, one is a food poisoning, another is an infection.
Okay, botulism.
Very good.
And polio.
Diphtheria. So these two are basically descending type of paralysis. Now, neuropathies are divided into sensory neuropathies and motor neuropathies. Now, my question to you is very good. We have one more in this group, Jitu. Yeah. Jitu, I sent you a request to join as a speaker. Can you accept so that your mic become activated? Yeah. I've sent you a request to join as yes, very good, very good. Hi, Jitu. What is your full name, Jitu?
Good evening, sir. My name is Jitendra Verma.
Wonderful, Jitendra. And you are from which place, Jiten?
Sir, I am from Uttar Pradesh, UP, Lucknow.
Very good, very good, very good, wonderful. So every day evening, for about an hour, we have this question answer session. We don't teach, we only inspire people to study. So that is the whole concept. Because nowadays so many videos are available on the YouTube, and people are quite blessed with a toxic doses of information. So that's the reason it's much better if we have someone every day taking opportunity to inspire. So that's the whole idea. So please feel free to answer, Jitu, the questions, right? So my next question is, neuropathies are divided into sensory neuropathies and motor neuropathies. Can you give me one classical example of predominantly sensory neuropathy? Any of you? Syringomyelia. Predominantly sensory neuropathy. It is an infection, actually. Which infection it is? डायबिटीज में सब कुछ होता है, प्योरली सेंसरी होने वाला होता है HIV. HIV is what you need to remember, right? Then, all right. Now, tell me one condition where in the lower limbs you get inverted champagne bottle appearance in the lower limbs. Lipodermatosclerosis. More classical condition. Tell me, inverted champagne bottle means we will remember that.
Sir, became muscular dystrophy,
DMD, you get pseudo hypertrophy. So Charcot-Marie-Tooth disease is once more the place where you get inverted champagne bottle appearance. That's what we need to remember. Now, doctor, we come to a very, very interesting area that we need to be ready for the next INICET. Channelopathies. Because of a channel defect, you get a particular disorder. Channel can be a potassium channel, calcium channel, sodium channel, chloride channel. Now my question goes to you. Episodic ataxia type 1. Which channel it is? Give a try of your luck. Any of you? Yeah.
Potassium or fluoride?
Potassium, very good. And hypokalemic periodic paralysis is which channelopathy? Is it potassium, sodium, or calcium? Make a guess.
potassium, sir.
Oh, it is calcium, slow calcium channel. Next, hyperkalemic periodic paralysis is it sodium, chloride, potassium, calcium?
Sodium channel.
Very good. And myotonia congenita and cystic fibrosis are?
Fluoride channel.
Very good, very good. So, this once more tells that channelopathy is such an important topic and you need to keep that in the pocket. And today's evening, our Chai Pe Charcha is the one which makes you to remember forever that channelopathies are the most important. So in the online, we have Akash Yadav who joined. So Akash, I request you to go to that link, twitterspaces.com/spaces, and that link which is I posted in the chat window on the YouTube. Just click on that, you can join just like our Sankit and Jitu Bhai. You two can join the discussion. We will have a small Chai Pe Charcha. Now, the next question. What is the cause of Hypertension? Hypertension is a chronic condition. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood vessels. It is caused by inflammation in the blood v Lambert-Eaton's myasthenic syndrome versus myasthenia gravis. If you look at these two, deep tendon reflexes differentiate them. Now tell me, in which condition deep tendon reflexes are preserved and where the deep tendon reflexes are absent or decreased?
Preserved in Lambert-Eaton and decreased in myasthenia.
No. See, what is lower motor neuron, doctor? Androphon cell or the nerve until the presynaptic area of the neuromuscular junction, right?
Yes.
So if you look at Lambert-Eaton, the pathology is at the presynaptic level. That is the reason still it falls in the definition of a lower motor neuron. That is the reason deep tendon reflexes will be absent or decreased in Lambert-Eaton. Whereas myasthenia is postsynaptic membrane. So postsynaptic membrane, muscle and everything, they don't come under lower motor neuron. That is the reason preserved deep tendon reflexes is a feature of myasthenia, decreased deep tendon reflexes is a feature of Lambert-Eaton. Could you follow me?
Yes.
Yes, sir.
Yeah, very good. Now, Lambert-Eaton and myasthenia, they both differ in terms of the involvement of the type of the muscle. Very important, right? So now my question to you is, between the two, which involves ocular and which involves predominantly lower limbs and proximal muscles of the lower limbs, that is pelvic muscles?
Ocular is myasthenia and pelvic muscles is Lambert-Eaton.
Very good. That way, Lambert-Eaton myasthenic syndrome is a small exception. So what is the exception? Generally, neuropathies involve distal muscles, myopathies involve proximal muscles. That's a general rule. But the Lambert-Eaton myasthenic syndrome, though it is a kind of a neuropathic involvement, but still it involves the proximal muscles of the lower limb is what you need to basically remember. Now, my next question is, what is the type of lung carcinoma which is most commonly associated with the Lambert-Eaton syndrome?
Small cell lung carcinoma.
Very good. The odd cell carcinoma is the one which is associated. Excellent. So that is a quick story. Now, doctor, my next volley of questions to you is going to be on rheumatoid arthritis. Get ready to answer. Now, my question is, of all the serological parameters of rheumatoid arthritis, what is the most specific autoantibody which is used to evaluate rheumatoid arthritis? You're able to get me? What is the most specific serological marker?
Sir, anti-CCP related.
Beautiful. Anti-CCP is most specific. Now, rheumatoid factors are basically the antibodies. Now you should tell me, they are which immunoglobulin class type and they are directed against which immunoglobulin?
Anti-G type.
Okay. Directed against? Hello? Hello? Am I audible?
Yes, sir.
Yes, sir.
So rheumatoid factors are the antibodies of the IgM class, which are directed against the Fc fragment of the IgG, is what you need to remember. Now, basically, rheumatoid arthritis involves, is it the PIP or DIP or both of them?
PIP is what? PIP is
Very good. And which HLA is associated with rheumatoid arthritis?
PIP.
In India, it is HLA DR1. In other countries, it is HLA DR4 is what you need to basically remember. Now, can you give few examples of seronegative arthritis? There are 5 conditions which are together called seronegative arthritis.
Psoriatic arthritis, reactive arthritis, Peter syndrome.
Very good. Beside, very good. Very good. Ankylosing spondylitis, Whipple's and Still's disease. Right? Now the question is, typically, of all the various inflammatory disorders which involve the joints, which one leads to the development of non-erosive arthritis? Non-erosive arthritis. Classically, if you take the radiograph, you don't find erosion, though it is an inflammatory arthritis. Which condition is that? Classical question.
Rheumatic arthritis.
Oh no, rheumatoid arthritis, you find classically erosions. It is erosive, painful. Classical is SLE, right? In SLE, typically it is non-erosive arthritis. If you take a radiograph, you find erosions, means it is unlikely to be SLE. You got my point?
Yes, sir.
Good. Then metatarsophalangeal joint of the great toe is classically involved in gout. Very good, very good, very good. Now, let's look at some treatment options in rheumatoid arthritis. Which is the treatment, which is the drug used in the treatment, which is a chimeric antibody, monoclonal antibody against CD20 that we use in rheumatoid arthritis? Beautiful. And which is the interleukin-1 receptor antagonist? Anakinra. Very good. And give me few TNF inhibitors in rheumatoid arthritis. Beautiful. Etanercept, infliximab, and adalimumab. Then, which is the fusion protein of CTLA4 and FC portion of IgG, which is used in rheumatoid arthritis? Abatacept, right? Abatacept is what you need to remember. And there are so many disease-modifying anti-rheumatic drugs that we use. Of all them, which do you call DMARD of choice that you use in rheumatoid arthritis? Beautiful. Methotrexate is the king of the chemicals, is what you need to remember. So, in summary, metacarpophalangeal joint involvement is classically seen in which 2 conditions?
Osteoarthritis.
MCP. Very good. Rheumatoid arthritis and SLE, MCP involved. Osteoarthritis and psoriasis, DIP involved. Right? You'll remember it for me?
Yes.
Good. Now, quickly tell me what are the triad of features of Felty syndrome?
Neutropenia, splenomegaly, and rheumatoid arthritis.
Very good. Very good. And in the case of the infants, what are the most common causes of the septic arthritis? Most common cause of septic arthritis in infants. Which organism?
Staph aureus.
You are very close, but not right. Staph aureus is most common of septic arthritis in older children and adults. Okay, I'll give you another clue. Shall I give a clue?
Yes, yes, sir.
This organism, if it leads to pneumonia, it leads to bulging fissure sign. Sorry, bulging fissure sign.
Klebsiella.
Oh, I'm sorry, it is Klebsiella, right? So, sorry, it is not Klebsiella in infants, so that was a wrong clue. Okay, this organism requires factor X and factor V. Correct. So the most common cause of septic arthritis in infants is H. influenza, is what you need to basically remember. Now, good. So let's talk quickly about Bouchard, Heberden, the two types of nodes of osteoarthritis, which is PIP, which is DIP.
Bouchard is PIP, Hypertension is DIP.
Beautiful, beautiful, beautiful. Now, what is the most common extra-articular manifestation of ankylosing spondylitis?
Uveitis.
Absolutely. Acute anterior uveitis is most common, right? Now, all right. So let us quickly check on gout versus pseudogout. Can you give me 3 to 4 conditions where you find pseudogout?
Hemochromatosis.
Hemochromatosis? Yeah, absolutely. Then, one endocrine condition? Very good. Diabetes, hypothyroidism, ochronosis, and hypomagnesemia. Where you find pseudogout is what you need to basically remember. Then what is the most common site for the pseudogout? Knee joint. Absolutely, absolutely, doctor. Now, what is the most frequent cause of the Charcot's joint? Neuropathic joint.
Diabetes.
Absolutely, diabetes is the most common. Now, yes. Let's go to few drugs that you use in acute gout and chronic gout. Tell me one drug which is used in chronic gout, which you should never use in acute gout. A drug used in chronic gout, which if you use in acute gout, it can worsen the condition. Classical question. Okay, what are the drugs used in chronic gout? Allopurinol, probenecid, sulfenpyrazone, febuxostat, and pegloticase. So out of all these, which you should never use in acute gout? Allopurinol is never used in acute gout, is what you need to basically remember. Now, in acute gout, in that case, what is the first line of therapy is my question to all of you. Absolutely. Indomethacin is considered to be the first line of drug, is what you should basically remember. Good. Now, doctor, yes. What is the most common cause for development of hypoparathyroidism? Most common underlying cause of the hypoparathyroidism?
Rheumatoid surgery, thyroidectomy.
Well, absolutely. Thyroidectomy is what you need to remember. Now, what is the effect of hypoparathyroidism on the ECG? What happens to, which part of the ECG is affected and what is the effect of it?
QRS complexly affected.
QRS?
Complexly affected.
Okay.
And then we bradycardia, then clarity of QRS.
So basically, hypoparathyroidism lead to hypocalcemia or hyper?
Hypocalcemia.
Very good. So hypocalcemia lead to prolongation of the QT interval, which is the classical feature of the hypoparathyroidism, is what you need to remember. Now, what is that clinical sign where the facial muscle contraction or tapping of the facial nerve in front of the ear called?
Swastika.
Very good, very good, very good. Now, now the question is, how are the PTH levels in hypoparathyroidism? Sorry, pseudo hypoparathyroidism. How are the PTH levels? Absolutely. And how are they in pseudo hypoparathyroidism?
High.
Very good, very good, very good. Now, can you tell me 4 to 5 features of the Albright hereditary osteodystrophy? How will be the stature? Will it be a tall, lanky guy, marfanoid, or short stature, or normal stature? Basically, pseudo hypoparathyroidism is also Albright hereditary osteodystrophy. So in them, they have a short stature, brachydactyly, obesity, and intracranial calcification and band keratopathy is what we need to basically remember. All right, that's good. You still have energy to take few questions?
Yes, yes, sir.
Good, good. So don't you think, guys, this is more interesting to learn and remember rather than listening to a lecture?
Sure, sir. Definitely, sir.
That's why. So I like, we are actually launching a mobile app shortly called Wongo. Wongo is an app that we are launching. So in the Wongo app, there will be thousands of audio chat rooms. Anyone can start the audio chat room or can join an audio chat room. And teachers can start and students can start, discover study mates and everything. So don't you think it would be, I mean, what is your opinion on such a kind of an app?
It'll be an interesting experience, sir.
Yeah, so I'm just working with my developers. By Monday, we are going to launch it. Additionally, what we are going to do is, in this kind of audio rooms, we are going to include a feature called gallery. So what happens is, suppose if I ask you a question, you can always, suppose it is a maths question, mathematical question. The student can actually write on a paper, just quickly take a pic and then upload into the gallery and everyone can be able to see that. But it is predominantly audio. Why audio is because even if you're staying in the home or you're in a hostel, library or anywhere, it is like switching on to a radio and then simply participating. And that is how knowledge should be democratized. So let's see, we doctors as entrepreneurs, some are very successful and few are will always have challenge, but I'm always a successful serial entrepreneur. Always playing with technology. Yeah, good. Now, my next question is, compression of a large retrosternal goiter creates which important clinical sign in hyperthyroidism? Very good. And now tell me, excessive thyroid hormone synthesis due to increased iodine exposure in hyperthyroidism, what is that phenomenon called? Very good. And what is Wolff-Chaikoff? Excess iodides transiently inhibit the thyroid organification leading to hypothyroidism is called Wolff-Chaikoff. Very good, very good. Now, do you get any cardiac murmurs in hyperthyroidism? If so, then what type? Is it diastolic, systolic, ejection, or end? What is the nature? You're able to get my point, right? Hello?
Yes, sir.
Yes, sir.
Yeah. So, am I audible?
Yes, sir. I could remember it as high output moments.
Okay. Yeah. So, yeah, it is a systolic ejection click, mid-systolic movement. Now, what is that systolic scratchy sound that you listen in hyperthyroidism called? Means Lerman scratch, it is called as, right?
Okay, sir.
Yeah. Now, my next question would be, there are two types of polyglandular autoimmune syndromes. One is called PGA1, other is called PGA2. Now, my question is, between the two, which one is this? There is a mucocutaneous candidiasis, hypothyroidism, hypoparathyroidism, adrenal insufficiency, dental enamel hypoplasia, malabsorption, vitiligo, pernicious anemia. All this, they are there in which polyglandular autoimmune syndrome? PGA1 or PGA2? Mucocutaneous candidiasis, hypothyroidism, hypoparathyroidism, adrenal insufficiency, dental enamel hypoplasia, vitiligo. All these are part of PGA1 or PGA2?
A1.
Very good. It is A1. A1. APECED gene. APECED gene. It is associated with PGA1 or PGA2? PGA1. Okay. Then HLA DR3 and DR4 association with a polygenic inheritance is PGA1 or A2?
A2.
A2. Try your luck. But you will remember like this in tomorrow's exam. Right? Because you exercise your mind, unlike passive reading, right? Which is autosomal recessive? PGA1 or 2? 1. And which is associated with type 1 diabetes?
1.
PGA2. So that is the nasty part of preparation, you know. After you get the seat, all this becomes a big joke, right? So now, give me a few syndromes known to associate with obesity, doctor.
Metabolic syndrome.
Okay. Genetic syndromes.
Lawrence.
Beautiful. Lawrence-Moon, Beadle syndrome. Then Prader-Willi,
Paralysis.
Cohen, Carpenter. These are the main things that need to be remembered. All right, that's good. Now, my question to you is, what is the drug of choice to treat diabetes insipidus? If it is nephrogenic.
Desmopressin.
Correct. Desmopressin is the drug of choice. So, if the lithium leads to diabetes insipidus, what will be the drug of choice? Will that be central or nephrogenic? Correct. In nephrogenic diabetes insipidus, what is the drug of choice? Chlorothiazides. Very good. So that is the whole paradox. Thiazides by themselves are diuretics, but diabetes insipidus is also a diuretic condition. So you are using a diuretic to treat a diuretic condition is the whole paradox. There's a reason for that. I discussed that many times in our video library and everything. So yeah, I don't want to go into that right now. Now, what is the drug which is an antagonist of the aquaporin receptors which are used in the management of diabetes insipidus? You understand my question?
Yes, sir.
Yes, sir.
Antagonist on aquaporin 2 receptors. Vaptans. Tolivaptan, conivaptan. Conivaptan is an intravenous drug. Tolivaptan is an oral drug which are used in the typically the management of diabetes. Insipidus is what you need to remember. Now, lithium lead to nephrogenic diabetes insipidus. Just to tell me 3 to 4 other causes of nephrogenic diabetes insipidus. Tonight I can be able to sleep very happily. Okay, one drug is an anti-cancer drug, one is an antifungal, one is an antibiotic.
Hypertension B.
Very good. Nephrogenic diabetes insipidus. Then antibiotic.
Aminoglycosides.
Beautiful. And what is anti-neoplastic?
Platinum-based cisplatin.
Beautiful, cisplatin. So lithium, cisplatin, amyloidosin B, aminoglycosides, they're all nephrogenic diabetes. Now, yes. Now, secondary diabetes insipidus, is there any drug which is a anti-epileptic which can cause it? Anti-epileptic which can cause secondary diabetes insipidus?
Carbamazepine.
Beautiful. And also, which drug in psychiatry that is known to cause secondary diabetes? Lithium. Okay. Now, tell me one systemic condition which can cause both central diabetes and also nephrogenic diabetes insipidus, both of them. One condition. I'll give you one clue.
Yes.
In this condition, you get lupus pernio.
Yes, sir.
Lupus pernio. And you get bilateral hilar lymphadenopathy in this condition. Sarcoidosis. Beautiful. Sarcoidosis is the condition that lead to both central and also nephrogenic diabetes insipidus is what you need to remember. Very good, very good, very good. Now, doctor, yes. Tell me the auscultatory findings of pulmonary hypertension. Very good. And classically, you will put a pen and see the heaving of the pen. What is that called? Left parasternal heave. Right? That is the classical finding on inspection, of course. Now, pneumococcus versus staphylococcus, which lead to bronchopneumonia, which lead to lobar pneumonia. Between staphylococcus and pneumococcus. Any guess? Am I audible?
Yes, staph causes lobar.
Okay.
And pneumococcal bronchial.
Just reverse. Pneumococcal is lobar and the staph causes bronchopneumonia. Okay. Now, Austrian Triad is a triad of things in the pneumococcal pneumonia. So other than pneumococcal pneumonia, what are the other two things in this triad? Have you heard of this Austrian Triad in India?
No, sir.
Okay. Infective endocarditis, meningitis, and pneumococcal pneumonia is called Austrian Triad, is what you need to remember. Now, pneumatoceles are characteristic of which type of pneumonia? Staph aureus. Very good. And which is called Friedlander's pneumonia. Is it Klebsiella, Staphylococcus, Pneumococcus, or Pneumocystis, which lead to the is called Friedlander's pneumonia. It is Klebsiella. Okay. So community acquired lobar pneumonia. That's what is the Klebsiella causes. Now, classical clinical vignette in tomorrow's exam is alcoholic, more than 40 years, diabetic or COPD, got pneumonia. What is the organism? Klebsiella, commonly, right? Now, Klebsiella more commonly involves upper lobe or lower lobe? You remember, K is Klebsiella is kite. Kite flies up, so upper lobe, right? Klebsiella is upper lobe involvement is classical. Now, Warthin-Finkel cells, where do you find?
Measles.
Very good, measles. Give me 2 to 3 causes of interstitial pneumonia. Interstitial pneumonia. So there is a lobar pneumonia, bronchopneumonia, interstitial pneumonia. Generally, all viral pneumonias are all interstitial, like influenza virus, right? Then mycoplasma, legionella, pneumocystis, they're all interstitial pneumonias is what you need to basically remember. Now, quickly pick up these 4 favorite questions of the examiner. The most common cause of community acquired pneumonia. What is your answer?
Klebsiella.
Community acquired, most common cause. Klebsiella definitely causes a lobar, community acquired lobar pneumonia, no doubt, but most common cause of community acquired pneumonia. Very good, Samir. Please join. I just sent you an invite to become a speaker. Samir, are you online? Accept the invitation. Yeah. I just sent you an invite to speak. Samir Upadhyay. Could you? Okay. All right. All right. So I'm getting back Sankeet. Samir, can you try to join, or you can raise hand? Am I audible, Jitendra?
Yes, sir.
Okay. We got Sankeet also back. Sankeet, are you back? Okay. Yeah, I think all right. So we got Sankeet. Sankeet, are you online, man? Okay, you sent a request. So request. Okay, I accept the request. Can now speak. Okay.
Yes, sir.
Good. This is not that user friendly. This platform, actually, Clubhouse is more user friendly. But anyway, next week we are launching Wango, and even you two can say to 4 to 5 buddies among your friends, saying that, hey guys, just join. We'll all meet up in a room and then have a discussion of about 100 questions. So that that's an easy way to come together and then have a discussion, right? Now, Yeah. So the most common cause of community-acquired pneumonia is Streptococcus pneumoniae. Then the most common cause of overwhelming post-plenectomy infection.
Pneumococcus.
Absolutely. Most common cause of hospital-acquired pneumonia, which is nosocomial. Enteric gram-negative. Yeah. Enteric gram-negative bacilli. E. coli, Pseudomonas, Klebsiella, they are very common. Yeah. And most common cause of lobar pneumonia.
Pneumococcus.
Very good. Then, okay. Curve 65 criteria. They are used for predicting the mortality in which condition?
In pneumonia, sir.
Community acquired pneumonia, CAP. Okay? CAP. That's good. That's good. That's good. So before we say goodbye to this wonderful evening session, I want to quickly ask you few things on the ECG, let's say. QT interval is decreased in which condition? Give me one reason. Increased, a lot of reasons are there, but in one drug toxicity, QT interval is decreased. What is that? Digitalis toxic. Yes, yes, yes. Then what is the normal QT interval? Normal QT interval. That is the end of the P wave to the end of the ST segment until the beginning of the T wave. That's called QT. So it is normally 400 milliseconds, otherwise 0.4 seconds. And when you call prolonged QT, if the corrected QT interval, which is QT divided by square root of RR interval, is called corrected QT. If it is more than 600 milliseconds, you call prolonged QT. Now, what is the effect of hypokalemia on the PR interval? Increased in the case of the hypokalemia is what you need to basically remember. What is the normal QRS duration?
110 milliseconds.
Very good. Typically, it is always less than 110 seconds. Sorry, 110 milliseconds or 0.11 seconds. That's right. Now, all right. You heard of WPW syndrome and Lown-Ganong-Levine syndrome, right? So both of them, PR interval is shortened. But what is the main difference between them? In which case you find delta wave, which case you don't?
Sorry, WPW and delta wave.
Right. Lown-Ganong-Levine may, there is no delta wave. Similarly, slurring of the initial part of the QRS is a feature of WPW, but not Lown-Ganong-Levine syndrome. That's what you need to basically remember. Now, I like to ask you, what is the dysalkyltemia where you find prominent U wave? Very good. And what is the earliest change that you see in hyperkalemia? Tall tented T waves, absolutely. And what is the effect of hypokalemia on ST segment? Very good. And how about hyperkalemia? Even that also lead to depression.
Yes, sir.
And what is the effect of hypokalemia on QT interval? QT interval become prolonged. And both hypo and hyperkalemia lead to widening of the QRS. That's what you need to basically remember. So that's good. So my yeah, okay. In inferior wall MI, where do you see the Q waves? Which leads? Beautiful, beautiful, beautiful. And all right. So I hope you all enjoyed this evening chai pe charcha with Dr. Murli Varadraj. So many more occasions. Every day evening, I'll take 1 hour of my time to spend discussing few questions. Next time, tomorrow we'll have a chai pe charcha on orthopedics, right, doctor?
Yes, sir. Thank you very much, sir. And I feel blessed by attending this session. Thank you, sir.
Any day, any day, any day. Thank you, Sanket. Okay.